So we're going to discuss the 2021 CPG upskilling for pregnancy and childbirth complications. We're going to talk about a few little bits on this. There's nothing majorly complicated. We're building on stuff that we already know. So we're going to talk about complications in delivery. We're going to talk about risk factors for complicated delivery. So we're going to have a quick look at that, a quick talk about that. We're going to talk about cord complications. Malpresentations and shoulder dystocia is going to be in another session. Post-pregnancy care is a new CPG which incorporates a couple of new bits. Neonate resus, less than 6 weeks, cardiac arrest or pulse less than 60. We're going to have a chat about this, neonate resuscitation. There's a practical session on this, so we're just going to have a quick chat about it, and practically we'll actually do that when we're here in the actual training centre itself. Okay. So, pre-hospital emergency childbirth, the CPG itself, there's a couple of changes to it. So we're just going to run through the algorithm really briefly. So if the patient is in labour, yes or no. Birth is imminent, yes it is. So we're going to request a second crew if we have one, because we're going to need a couple of extra bodies. So we can, we'll have a look at this here. So there's a number of boxes around it which we'll talk about. In fact, we're going to go through this really quickly on a couple of the following slides. The actual algorithm itself is pretty easy to follow. There's a couple of extra information boxes which we're going to touch on now in a second. So, they're in labour, yes. So is birth imminent? So if it's not imminent, we're going to consider transporting, and we'll follow out where that goes, and it's going to be to a dedicated obstetric unit. So if they're definitely in labour, then we're going to have to stay and do what we have to do if birth is imminent, should I say. So birth is imminent, yes. Request a second crew. Cord complications, if it is, then we'll go to that particular CPG. If there's an issue with a malpresentation, we'll go to that CPG. If there's risk factors, yes or no. So if there's no risk factors, so we get the mother to adopt a position of comfort. We prepare the place as we would normally do if we're going to do business at home. We create a sterile area. We'll prep the mom with the likes of pads under her and stuff like that, and we'll get the place ready for the delivery of a child. We'll also be cognizant of the fact that when the child arrives, there may be issues. So we may have a post-vaginal bleed after the birth, so we would prep for shock. We may have an issue with the child itself not breathing, so we'll also prep for neonate resus. And these are the things that we would go through normally during a childbirth, the things that we would be prepping for, shall we say. So, we'll run down through here. If there is risk factors and we have a little bit of time, we'll initiate rapid transport, pre-alert the labour ward, and optimise the resuscitation of the mother. In other words, we're going to be giving her oxygen therapy, raising the legs, promoting blood flow to the brain and the core, and doing what we would normally do. So, when we get to the bottom half of the CPG, so our aim on this particular part of the algorithm here is birth in the hospital, if possible. Now again, this is going to be dependent on how far from the hospital we are. If we're in one of the major cities like Dublin, we may be 10, 15, 20 minutes from a hospital. If we're somewhere like West Cavan, you could be looking at a minimum of an hour on really bad roads to get into an obstetric unit. So we need to be weighing the geographical factors of where we are and where we're going to go against what we're looking at, with the presenting mother as well. So, here we go. So the mother, monitor vital signs. So we have a baby, we'll support them during the delivery. The baby themselves, we'll warm and dry them and stimulate them, always dry them. Make sure that we conserve heat. Remember, they're not generating much heat themselves. Clamp or cut the cord, and then we can initiate skin-to-skin contact with mom to maintain body temperature. The mother herself, checking for a second baby, absolutely. And again, these are the questions we'll be asking parents prior to delivery. Is there more than one child? Has there been complications with the delivery? Is there anything special we need to know about your physiology? Do you have any transmittable diseases? All the usual questions we would normally ask, and then we will check again. Being mindful, I suppose, in the society that we live in now, maybe 20 years ago, the majority of our patients would speak English. Depending on where we're living geographically, and I don't think there's any county that encounters this now, there is, people from other countries where English is not their first language, where parents actually don't speak English, so we need to be mindful that there's barriers there to getting information too. So the mother is delivered, there's no second child, paramedics will consider oxytocin. We can encourage breastfeeding in mom, which will promote oxytocin naturally in the system, and it will bring on the birth of the placenta itself. The mother is stable? No. Then we go to primary survey, secondary survey, and we would manage shock perhaps. Mom is stable, skin to skin contact with the baby, as we've mentioned already. Try and maintain that core body temperature of the child, who is not going to maintain their own temperature at all. Encourage breastfeeding if there's no contraindications. Again, it stimulates the release of oxytocin and encourages the placenta to be delivered. If the placenta delivers, bring to the hospital with the mother, and always, pop it into a yellow healthcare risk waste bag. Make sure you have all of it, and make sure it's sealed. So, and then we're into reassess, and we're traveling to an obstetric unit. There's a number of bits around here. Wait at least 1 minute post-birth. Clamp the cord at 10, 15 and 20 centimetres and cut between 15 and 20. So we've 2 clamps between the baby and the cut, and we've 1 clamp between the cut and mom. Okay. Risk factors for complicated deliveries. Again, this is just a little tool for, what are we dealing with initially. If we have risk factors, it just adds extra parameters into what we're thinking about. So prematurity, so these are the questions we would ask. How far along are you? Are you full term? Have you had problems with this pregnancy? How many babies have you had already? Has there been previous complications? Have you any issues with your health, etc., etc.? Has been issues with the pregnancy? Have we been having visits to the hospital? Because some people haven't. So multiple births. If there's more than one child, it's quite likely you're going to have a breach on one of them. Hopefully, it won't be the first one. But really, this is something that we need to know about. Post-vaginal bleeds are a consideration. Preeclampsia indicators. Again, you've talked about this on your original qualification. We have a consistent hypertension, which will predispose mom to seizures and again endanger her life and the life of the child. There will be history of that. We can physically take blood pressures, and we'll have a talk about that too. Any trauma? Has there been a trauma? Are we called to the side of a road to a car accident where mom was driving or a passenger, and this has actually brought on a labour prematurely? So we need to be considering this stuff. Possible abruption if there's a major trauma. History of anticoagulant use or bleeding disorders. Yep, absolutely. What else? History of female genital mutilation. Yeah, so there is a small amount of females who've had genital mutilation, and it creates issues for the birth of children. So we need to be considering that kind of stuff. Meconium. So if there's meconium in the water, if there's green in the water, the fetus has actually defecated within the womb itself, we need to be mindful of that, because that can cause issues with breathing, further on up the road. Placenta previa or a low placenta, a stitch in the cervix or diabetes. Any of these things are considered, potential risk factors for complications. And here's the box itself, blown up, happy days. Diabetes itself, even gestational diabetes in a woman, if it hasn't been treated effectively, will encourage, even on a forced birth, if it's a girl who hasn't been treated for the likes of gestational diabetes, which is unusual, but if she hasn't, it can encourage the child to grow quite big, and it can create major problems for the delivery of the child. Cord complications. Request ALS, absolutely. If we can request ALS for any pre-hospital childbirth, we should. It's always about giving the child the best chance. If we're in a rural community, we might request a local midwife or doctor if they're around, because all the hands that we can get, especially ones who have far more specialist knowledge than ourselves, give a much better chance of a safe and normal delivery than what we would normally have. Okay. Cord complications, it talks here about using a hands-off approach. Absolutely. Any stimulation of cords themselves can inhibit the cord's function for pumping blood and taking blood back from the fetus. It can create spasm in the cord itself, which means the child now no longer gets fed. So a hands-off approach really is the big thing. Avoid touching the cord if possible, and avoid manipulation or pulling on it. Okay, treat it very gently. Pre-alert the hospital at the earliest opportunity. So any cord complication has the potential to end the child's life. We again need to be, alerting EDs within the obstetric hospitals, alerting the wards, and seeing if we have any specialist help in the area that can come and help us out. So oxygen therapy, for sure. Cord around the baby's neck. So avoid excessive manipulation or pulling on the cord. There's quite a significant amount of evidence that cords are long enough for a baby to be born, even if a cord is around, but not multiple loops. So one loop is, in general, it will deliver fine, and we can pop the loop off, and we'll discuss that in a moment. A cord rupture itself, we're talking about additional clamps to the cord on either side of the rupture. This is after the child is born, just to make sure that we don't lose that precious blood from the fetus itself, or indeed from mom. Apply direct pressure with a sterile dressing. So we have a cord rupture, we're going to clamp either side of the rupture itself, apply a sterile dressing, and inhibit that bleeding. A prolapse cord, mother to adopt the head down, left lateral. So she's going to present. So what we're going to do is have mom's head down. And she's going to lie on her left side. So we're going to have a line over on the left side, head a little bit lower. It's taking all the weight off the inferior vena cava and promoting venous return to the heart, and it's keeping all that blood in the core where it belongs for the baby and for the mom, so that we're getting cerebral perfusion. Great. So, hold presented part off the cord using the fingers is only for paramedic. Minimal handling of the cord and cover with a sterile pad. That's the biggest thing. Prolap cord, cover the cord, don't handle it, leave it alone. Keep it moist. We're heading for the ED, we're heading for the emergency department within the actual obstetric hospital. That's what we're doing. So prolonged transport time of greater than 15 minutes, an advanced paramedic could potentially put in an indwelling catheter. Again, if we have ALS available, we're going to invite them to the scene as EMTs. We're going to be very cognizant of the fact that there's limited stuff that we can be doing here. Again, rapid transfer to the obstetric unit, that's the whole goal here. Okay. Changes from the 2017 CPGs, and there's a few of them. So the changes to sequence steps for the management of cord around the baby's neck. So hips higher than the head and left lateral recumbent is a new thing. This wasn't in the old CPG, so this is a change. Rapid transfer to obstetric unit mandatory sequence steps has been added. So if we have the time, it's far better. The aim, as it says in the CPG, is to deliver the child in hospital if possible. It's safer for the child, it's safer for mom. Pre-alert hospital for possible emergency cesarean due to cord prolapse. That's been added as a new information instruction box, and that makes sense. That's something that we will be doing routinely anyway. It's just been added to the CPG. Request ambulance control information instruction box is removed. So, in your wisdom, you would always inform your control centre and have them pass information on. So they will become a conduit for information. That's really what this is about. Umbilical cord complications. So requesting ALS, that's something that we would normally do. Remember, the umbilical cord is the lifeline. It's the lifeline for the child, for the fetus, for the unborn child. Requesting ALS, both for the child and for the mom, is giving everybody the best chance to keep them safe if something goes sideways. Nuchal cord, so cord around the baby's neck may occur in 20 to 30% of deliveries. However, it's not really a major problem. One loop of the cord can deliver normally. There shouldn't really be a big issue with this. Avoid excessive manipulation and traction on the cord. If the cord is seen around baby's neck, it can be left alone. There you go. The body will usually deliver through the loops, which is fine. Adverse outcomes are usually only associated with multiple loops, which, they're very, very infrequent. Cord prolapses occur in about, less than 1% of delivery. So in general, it's not stuff that we're seeing. And I know from colleagues, pre-hospital childbirths, 90, 95, 98, 99% of the time, nature does its thing and the child delivers normally and safely. And that's what we're hoping for. However, if there's any indication of risk factors, the big aim is to deliver in hospital if that's what we can. So, post-pregnancy care, including miscarriage and abortion. This CPG itself, we're talking about less than or equal to 6 weeks postpartum. So up to 6 weeks after delivery of the child, this CPG covers. So we're talking about if it's the likes of a heavy PV bleed, we've had a PV bleed, the mom was pregnant. We're talking about considering retained parts of conception. So we can get small parts of fetal bodies and stuff like that, and we need to keep them. And again, it'd be a yellow healthcare risk waste bag. We need to see what there is. We need to see if there's anything retained inside mom. She may need to have a procedure like a DNC to actually clean the inside of her womb itself. Okay. Post-vaginal bleeding, no, there's no post-vaginal bleeding. No signs of sepsis. Then we're heading to the obstetrics unit, always to the place of best care, which is the obstetrics unit. Post-vaginal bleeding and signs of shock, yes, okay. Request ALS, absolutely. What can we do as EMTs to look after somebody who's in shock or hypoperfusing? Again, a big thing, legs in the air. If they're heavily pregnant, left lateral recumbent. If they're in the early first trimester of pregnancy, legs up, head down, promoting blood flow to the core, oxygen therapy, keep the patient warm, reassure and talk to them. That's the big thing, isn't it? So again, we'll run down through the algorithm, request ALS. They may or may not do a couple of bits here. Consider breastfeeding if there's no contraindications. So, run through the actual algorithm itself. This is pretty straightforward. For ourselves, for EMTs, there's very little that we're at. If we suspect sepsis, we're going straight to the sepsis CPG. If we have a delivery greater than 20 weeks with a headache, visual disturbance, difficulty breathing, swelling of the legs or a seizure, we're considering the fact that she may actually have preeclampsia. So if we get a measurement of blood pressures greater than 140/90 and we get 2 of those consecutive pressures together, then we can consider her preeclamptic. And again, if we have ALS, there's interventions ALS can do. If there's not, we're running to the general ED, because the general ED is where we want to be going with this patient here. An altered mood, we can consider mental health CPG, which we can go to. We can assess home environment support and report this on handover and take this to the hospital with us. Again, unless there's evidence of active labour, this will be going to the general hospital. Suspect preeclampsia if the above symptoms persist. There's 2 elevated BPs, 15 minutes apart, both of them greater than 140/90, then they're preeclamptic. Some of the other stuff here, additional sepsis symptoms, low back pain, post-vaginal bleed or post-vaginal discharge. On top of our other symptoms, these will be additional ones for the pregnant person that we'll be considering. Post-pregnancy care itself. So this CPG replaces and combines a number of the 2017 CPGs. So post-vaginal hemorrhage in pregnancy and postpartum hemorrhage. We also have post-pregnancy less than or equal to 6 weeks, including miscarriage and abortion, which is what we've just looked at. Following clinical assessment, treatment pathways have been added for post-vaginal bleeding, for sepsis, for preeclampsia, and for altered mood. So what we've done is we've combined a number of CPGs into one, which is replacing the original 2017 ones. So consider again breaking the CPG down as we had a look. Post-vaginal bleeding, signs of shock, no, we're going straight to the obstetric hospital. Signs of shock, yes. Request advanced life support if we can. Sepsis is going to the sepsis CPG, part of the algorithm. Delivery greater than 20 weeks with a headache, visual disturbance, dyspnea, edema in the feet or seizure. 2 consecutive BPs of greater than 140/90, 15 minutes apart. 2 of them makes them eclamptic. We can ask for advanced life support if we have them. They can give the likes of magnesium sulfate. This patient, if they're not in active labour, are going to the general hospital. Altered mood, consider the mental health CPG, assess the home environment, repress findings, and again, this is information we're taking to the hospital with us and trying to link into social services. So, we're just following the algorithm down. So this algorithm here is starting on your post-vaginal bleeding and your sepsis. So your post-vaginal bleeding, my apologies. So your post-vaginal bleeding on the left side of the algorithm here is really for your advanced life support. One of them here is for your paramedic. There's nothing in it for EMTs at all. We're heading to the hospital. Signs of sepsis, we're going to have a think about sepsis. Yeah, then we'll go to the sepsis CPG. The additional considerations will be a post-vaginal bleed or discharge. With regards to headache, visual disturbance, difficulty breathing, edema or seizures, we're talking about our preeclampsia. And that's just running down again. All of the treatment plans in there are really for your advanced paramedic, and they're going to the general hospital. Again, the general ED. The change in altered mood, considering the mental health CPG, we're going to the general hospital too. So we're suspecting preeclampsia if the above symptoms present 2 elevated readings above 140/90, 15 minutes apart. So that's a new CPG. Okay. Neonate resus. So neonates less than or equal to 6 weeks. This is just a bit of a chat. Again, this is a recap on what we should already know. There is a practical on this in the training centre which we'll be doing. So this is just a real short run through on a video. It's a couple of minutes.
started neonatal resuscitation, it is paramount that you check the equipment is working. Switch on the resuscitator, turn on the light, and make sure you have adequate heat. You can see on the dial how you can adjust the heat power accordingly. Start the clock immediately and note the time of events. When you receive the baby, it is important to dry the baby and then wrap the baby in a clean, warm towel. Once the baby is in a nice, clean, warm towel, you need to expose sufficient amount of the baby in order for you to visualise the infant's chest. Assess colour, tone, breathing and heart rate. It is important to use the stethoscope as gold standard when auscultating the infant's heart rate. If the baby has no heart rate, or the heart rate is less than 60 and the baby is not breathing, you must give 5 inflation breaths, sustaining the inflation pressure for 30 centimetres of water for 2 to 3 seconds. Following this, if the chest has risen, reassess the tone, colour, breathing and heart rate. If the heart rate is still below 60 or absent, commence compressions, a third of the depth of the infant's chest at a ratio of 3 compressions to 1 ventilation, and continue this procedure for 30 seconds. You can see how it is important to compress the infant's chest a third of the depth. Following 30 seconds of this sequence, it is important to reassess. If the baby's heart rate is above 60 and improving and present, however the baby is not breathing, continue with ventilation breaths at a ratio of 30 breaths per minute. Again, within 30 seconds of completing this, you must reassess again colour, tone, breathing and heart rate.
And again, this is just your 2-finger CPR instead of the wraparound thumbs. So, that there is just a little short demo on neonate resus, which we're going to do practically. In a training centre when you pop in. Neo-resus, less than 6 weeks. Here's the actual algorithm itself for you to have a look at. You guys, I'm sure, are looking at this algorithm yourselves online. Initiate mobilisation of 3 to 4 practitioners responders, which we did before. So, cardiac arrest or a pulse of less than 60. Remember, if their pulse is between 60 and 100, we will be ventilating at a rate of, remember what they said? We'll have a look now in 1 second. If the pulse is less than 60, it's going to be CPR at a rate of 3 to 1. 3 compressions, 1 ventilation, 2 thumbs, hands encircling method, or the 2 fingers in the centre of the sternum. 5 positive pressure ventilations, which is at room air only. There's no supplemental oxygen, so it's less than 30% O2, which is going to be room air. Request ALS, always commence chest compressions, so 3 to 1 until the defibrillator is attached, and apply your AED pads. So if it's a shockable rhythm, it's 4 joules per kilo. Defibrillate. For EMTs, you'll be using pediatric defibrillation pads. The actual machine itself, being biphasic, it will measure the resistance and deliver the appropriate amount of energy. So assess the rhythm. Non-shockable rhythm is asystole or pulseless electrical activity, or PEA, in which case we'll just be doing the CPR. Immediately resume CPR for 2 minutes. If nothing changes, rhythm check, and then we're either doing our VTVF or ROSC or the asystole PEA algorithm, which we can have a chat about in the training centre. The 3 to 1 CPR, compressions to ventilation ratio using your 2-thumb encircling technique, or we can use the 2 fingers on the sternum itself. Use pediatric defibrillation system, which is fine. It means you do not need to adjust the energy on the actual machine itself. I know it says 4 joules per kilo. This will be for your advanced life support. Consider changing defibrillator to manual mode. That's only for paramedic. Advanced paramedic has got his own stuff there. The only thing you're looking at is initiation, the mobilising of 3 to 4 practitioners to give you a hand with the arrest. So, replace the 2017 CPG BLS neonate less than 4 weeks. This is now a new CPG. Clinical indicator, cardiac arrest or pulse less than 60. If the pulse is less than 60 beats per minute, it's considered cardiac arrest. It's considered inadequate perfusion. So the patient will die if you do not intervene. So, pulse is less than 60 with signs of poor perfusion. So the patient is central or central cyanosis, which is quite common. Pathways for shockable and non-shockable have been popped in. For you guys, you know, if you're running an AED, it's important to understand these things, but really you're going to be following the prompts of the actual AED itself. That's going to decide if it's shockable or non-shockable, if that's what you have, okay? You're going to use the pediatric defibrillation system, pediatric pads, which measure resistance between the pads, and the machine will deliver the appropriate energy. Rhythm checks, directions to specific CPGs for VFVT, asystole PEA, or for ROSC, okay? So, let's have a look at it in depth. Again, we've just ran through it, and this is just splitting the CPG from top to the bottom again. Initiate mobilization of 3 to 4 practitioners, 5 PPVs, oxygen therapy just with room air on the bag. Request ALS, commence your 3 to 1 chest compressions. So make sure your defibrillator gets attached, then we're going to follow the defib prompts. Attach the defib pads, compressions to ventilations are 3 to 1, using your 2 thumbs encircling or your 2 fingers. You're using your pediatric defibrillation system. Again, we're assessing the rhythm. If we have a manual machine, we're either going to have a shockable rhythm or a non-shockable rhythm. So your shockable is your VF or VT, it's 4 joules per kilo, and we'll shock that. Your non-shockable is going to be asystole or PEA. And if that's the case, then we're just going to work it for 2 minutes. Even if we defibrillate or not, we're always going to work it for 2 minutes if we're considering cardiac arrest. We have a rhythm check. We're either going to our shockable rhythm or non-shockable rhythm, which again would be more of the same, your 2 minutes of CPR, or we're going to our post-resource care CPG, okay, which is a separate one. Cardiac arrest rhythm recap. So again, here's your asystole. There's no electric activity going on in the heart. Asystolic. Cardiac arrest with no electricity. Treatment is high quality CPR and advanced life support. That's fine. So this is your ventricular fibrillation. You can see there's no P wave, no QRS complex associated with it, and no T wave. It's complete chaos. We have literally got electrical chaos, an electrical storm going on in the heart, and the heart is just quivering uselessly and it's not pumping blood. This is a shockable rhythm. Non-perfusion lethal dysrhythmia requires defibrillation. So this one here, again, is it regular? There's regularity to it. There's no visible P, Q, or S or T. The actual rhythms themselves are broad and bizarre, so we know that they're ventricular in origin. And if we look at the actual count the big boxes, I mean, it's over 150. So this is ventricular tachycardia or VT. Maybe perfusing or non-perfusing I would suggest in the likes of a neonate, it's not going to be a perfusing rhythm. Non-perfusing requires defibrillation. If it's perfusing adequately, we don't shock. However, in a neonate, we would consider it whatever the machine tells us to do is what we would be doing. Cardiac arrest rhythms, PEA. So it can be virtually any organised ECG rhythm. It can be any ECG rhythm. It can look like a normal rhythm. It can be just a slow version of same. However, we don't have a palpable pulse. The electrical system is working, but the pump is actually not pumping. It's not responding. Okay. Again, this rhythm here is treated with high quality CPR, and if we can get advanced life support on scene and try and lift the resuscitation effort, that's what we do. Okay. This particular one here can be, I mean, it looks like a normal rhythm, PQRST, PQRST, PQRST. 2, 3, 4, the rate on that is 75. I wouldn't expect to see this in a neonate. However, this could be what you're looking at. It's very organised, but the patient has, no signs of life. They have central cyanosis, they have no signs of perfusion, and you cannot palp a pulse. That this is PEA, and this is a rhythm that needs to be resuscitated. So asystole PEA pediatric, here's the actual algorithm itself. Have a look at it. It's quite consistent with the last one. There's nothing really funky about it. Have a read of it. We'll talk about it here in the training centre when you're doing your practical. We talk about hydrogen ion. I'm talking about H's and T's over here. Reversible causes, it's fine. A, B, C, D, E. So, post-resus care pediatric. So we've got a ROSC on a ped. Here it is here. We're going to maintain oxygen therapy, which indicates this child may very well just be a bag and mask. Without any kind of oxygen supplement, it may just very well be a bag and mask until the child shows good APGAR. So request ALS. Are they conscious? Yes. Avoid warming. Maintain patient at rest. ECG, SpO2, blah, 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 blah. So they're not conscious. Is there adequate ventilation? No. Positive pressure ventilations, 12 to 20 per minute, maybe a little bit more if it's a, if it's a ped, if it's a very young ped, but if they're 1, 2, 3 or whatever, yep, 12 to 20 per minute. Again, avoid warming. We don't want to, we're not actively cooling, but we're avoiding warming. Okay, and we're keeping that kind of cellular metabolic rate nice and low. Maintain patient at rest. Yep. ECG, SpO2 monitoring, monitor vital signs, check blood glucose levels, maintain care until handover to the appropriate facility, and contact ambulance control. Always keep people in the loop and plug the next handover in line, the next level of care, keep them in the loop as to what's going on. So, maintain oxygen therapy, here it is here, broken in half. ALS, conscious yes. Again, we're running down to the end of the algorithm. Conscious no. Adequate ventilation, yes, we're running down the bottom of the algorithm. Adequate ventilation, no, we're going to give them PPVs. And then we're going to follow the algorithm here, which is avoid warming. Maintain the patient at rest, ECG, SpO2 monitoring. Monitor vital signs, check blood glucose, maintain care, and keeping everybody in the loop, knowing that we're going to be running to a care facility with this patient. Okay. Reversible causes are something that's nice to know at EMT level. It's not need to know, but it's nice to know. Hydrogen-acidosis, H's and T's we call them. Hyperkalemia, fine, we're talking about potassium levels, we're talking about calcium levels, hypothermia, hypovolemia, hypoxia. So hypothermia we can address, we can cool the patient. Hypovolemia we can address and take care of external bleeds. Hypoxia we can address by either foreign body area obstruction or by actually ventilating the patient. T is thrombus, pulmonary, cardiac. Tamponade, I mean, if it's post trauma, we can try and take care of some of these. Tension pneumothorax, toxins, again, identifying toxins are a big thing with pediatrics. What do? Kiddies put everything into their mouth, little boogers, and trauma itself. So reversible causes of H's and T's we'll have a chat with practically when we're in the training centre as well. So summary, the 2017 edition, 4 pregnancy related CPGs. 2021 has 6 of them, 4 of which are new. 1 of which does not apply to EMT. Introduction of risk factors for complicated delivery, just to, so we understand and we're cognizant of the fact that there may be negative potential outcomes up the way. Identifying a risk factor may actually mitigate it if we spot it early enough. Umbilical cord complications, change to the CPG, hands-off approach, so avoid manipulating the cord, leave it be. Malpresentations, breech, face, brow, difficult pre-hospital deliveries. Yeah, they are. Knowing that, that they're difficult is the important thing. It means we may very well early initiate transport instead of kind of waiting around and hoping that stuff will work itself out. Complications pre-hospital we do not want. If there's going to be complications and we can make it to the hospital is the safest place for the mom and for the child. Shoulder dystocia we're not going to discuss at EMT level, but it's something that you can educate yourself on. Post-pregnancy care, pathways for PV bleed, sepsis, possible preeclampsia and altered mood. So we had a look at them in depth and how they're sitting on the CPG. Newborn neonate care and resus, neonate resuscitation less than 6 weeks. Newborn neonate care and resus details, management sort of heart rate, less than 100 PPV for 30 seconds. Heart rate less than 60 is CPR at 3 to 1. And again, this is something we reiterate here in a practical session. Resuscitation and neonate resus deals with cardiac arrest or a heart rate of less than 60 with signs of poor perfusion. So that's really all of it. There's a little bit in it. And again, I think any of the changes, some of them are quite subtle. We can discuss it on the practical element of the actual upskill itself. And there's some references there for you guys.